Hello, my name's Andrew Billnitzer. I'm an assistant professor here at the Stanley H. Appel Department of Neurology in the field of movement disorders. And today I'll be talking to you about deep brain stimulation and Parkinson's disease. So I'd like to start off our talk by first talking about one of the typical patients that we see here. In this case, it's a 69-year-old gentleman. He has a 12-year history of Parkinson's disease. The initial symptoms were a right hand rest tremor and then bothersome bradykinesia. He was started on levodopa therapy and responded well to the medicine over several years. But in the last few years, the levodopa began wearing off, meaning that the medicine was not lasting the course of the full day and he was having a return of his Parkinson's symptoms. And despite other adjunctive medicines to try to optimize this levodopa, he also developed what we call dyskinesias, which can sometimes be involuntary movements like head bobbing, leg jerking, or other types of involuntary movements. The symptoms continued to respond to levodopa whenever he was on the medicines, but now he estimates that about 50% of the time that he's spending throughout the day, he either has these bothersome dyskinesias or he's in what we call the off state. Just a reminder, Parkinson's disease is a condition that was first named by James Parkinson back in the 1800s. The peak age of onset is around 60 years of age. In the United States, there's about a lifetime risk of 2% for most patients. It's typically characterized by symptoms of bradykinesia, tremor, postural rigidity, instability, and you can also have some other non-motor symptoms such as autonomic dysfunction, such as orthostatic hypotension, constipation. You can have some cognitive symptoms or other neuropsychiatric symptoms such as depression or anxiety. The condition itself is caused by loss of dopaminergic neurons in the substantia nigra, and the mainstay of treatment is supplementation with levodopa therapy, for which most of the symptoms respond. Over time, as Parkinson's disease advances, there's a reduction in both the endogenous dopamine and a reduction in dopamine storage capacity in the brain. Oftentimes, this equates to patients not being able to appreciate as long of a benefit after they take their dose of levodopa, or that they see more labile swings in the concentration that can lead to some of the side effects, including those troublesome dyskinesias. They might feel that their symptoms come on before the next dose, or what we call wearing off. And they can also have changes in their gastric emptying due to autonomic dysfunction, and this can lead to erratic absorption of the medication. And this over time can also lead to symptoms where they might even take a dose or might notice that there's either no on symptoms at all or that the symptoms come back unpredictably at times. This tends to occur after about 5 years of therapy for most patients with levodopa with Parkinson's disease. This is a model of Parkinson's disease progression over time as it matters to levodopa. So the white area in the middle here is what we would call in your on therapeutic window. And you can see that early on in the course of the condition, it's a nice wide therapeutic window, but over time, your threshold for developing dyskinesias becomes lower, and your threshold for needing relief from off symptoms also increases. So we have to thread that needle, and we can do this with adjunctive medicines, but if those fail, then we start thinking about other more advanced options. One of these options is deep brain stimulation. This is a surgical technique in which one or more electrodes are implanted into targeted brain areas. These electrodes are attached to an implanted pulse generator that's either placed subcutaneously under the chest or in the abdomen. And these electrodes deliver electrical stimulation to modulate or disrupt patterns of neural signaling. What this does is essentially creates a reversible lesion in the brain and can help to mimic the effects of dopamine in the brain. This is a therapy that's been approved in 2002 by the FDA. It's an adjunctive therapy, like we talked about, that reduces some of the symptoms of advanced levodopa-responsive Parkinson's disease that aren't controlled by the medication. So important distinction there. So if we were to look at our model again, we can see that over time, as that therapeutic window narrows, we're trying to thread the needle. And rather than stretch out the doses of levodopa or do smaller, more frequent dosing, DBS is essentially a tonic activation of the brain that can mimic dopamine stimulation, and that's the goal of therapy. This is an example of DBS. This is our typical patient. You can see that the electrode is here in the brain. It goes into these deep brain nuclei, either the globus pallidus internus or the subthalamic nucleus, and then it's attached to these leads that are subcutaneously tunneled and leading to this pulse generator in the most patients, the chest. How does it work? If you direct your attention to the right, you can see that the neurons that are directly adjacent to the stimulation or within the field of stimulation are inhibited. So that's what we talked about, creating that lesion. Other areas of the brain, including some of the fibers coming off the neurons that we call axons, can be stimulated, and we can come into some issues with accidentally stimulating these where we don't need to, and that's where some of the side effects can come in. There's a few other mechanisms that we won't get into, but just know that aside from inhibition of cell bodies and maybe stimulation of axon, there can be some neuroregeneration, increased blood flow, and changes in neurotransmitter release. So it's a little more complicated than just creating that one lesion. This is a DBS that's been placed in a patient. You can see we call it deep brain stimulation because it really does hit the deep brain nuclei. It is a pretty minimally invasive neurosurgery. The electrodes are guided carefully through either imaging or something called microelectrorecording, and then the leads exit the skull and continue subcutaneously down to that IPG. Why does DBS work? This is a model of the basal ganglia, and the dopamine neuron, the input is coming here from the substantia nigra. And when you have that dopaminergic input, there's a balance between excitation and inhibition in the brain that will facilitate movement. But once we lose that stimulation, you can see that there's a lot more inhibition, especially along this pathway that we call the indirect circuit. And that inhibition goes through these deep brain nuclei. One is the globus pallidus internus, and one is the subthalamic nucleus. And both of these deep brain nuclei inhibit the thalamus, which is what promotes movement. So the goal of deep brain stimulation is to turn off these two inhibitory nuclei. That should reduce this inhibitory stimulation, and then you should see an increase of excitation and movement function coming from the thalamus. So that's the thought behind it. We talked briefly, and I'll talk more. These are the two targets that we look at. So the globus pallidus internus and subthalamic nucleus are both viable options for deep brain stimulation. Both will improve motor symptoms and tremor control. Both will lead to a reduction in what we call off time. The globus pallidus internus will reduce patients' dyskinesia through direct stimulation. The subthalamic nucleus, we're able to reduce patient dyskinesia because we're also able to reduce the amount of medication that the patient is taking. We often will use the globus pallidus internus because it's a little more of a robust target if we're worried about patients who have some other kind of borderline characteristic that make them a little riskier for DBS. This might include things like some cognitive decline or mood symptoms, or if they have some gait or balance issues. So that you tend to see a little less side effects when we stimulate the GPI compared to the STN. Like I said, the STN, most patients prefer this target as it can lead to a reduction in their overall need for levodopa therapy. Not eliminated, but most patients can get by on a lower dose. It also tends to require less electricity, so the battery will tend to last longer in these patients. There are potential risks related to the procedure. There are surgical risks, and then there are stimulation-related risks. The surgical risks include intracranial hemorrhage, infection, seizure, fracture of the leads or migration of the leads. And specific to the procedure itself, patients may develop a decrease in verbal fluency. And because of this, all patients are given neuropsychological testing to make sure they have cognitive reserve and might be able to withstand that hit if it happens. There are also stimulation-related adverse effects With these are reversible, and it's based on the actual stimulation. These can be anywhere from difficulty with speech, balance or disequilibrium, trouble with swallowing and dysphagia. Other new motor symptoms or sensory symptoms, patients might have pulling or tightening of muscles or funny sensations on their arms and legs. Over time, STN can have side effects of cognitive impairment, memory deficits, or in very rare cases, patients might develop mania, worsening depression, anxiety, or suicidal ideation. As we talked about, those side effects can be a little more common in the STN compared to GPI stimulation. So what makes our patient a good DBS candidate? As we've talked about, first and foremost, symptoms need to respond to levodopa therapy. That's another way of saying that DBS is not a last resort that we use when all other medications has failed. In fact, it's the opposite. If you don't respond to levodopa, we don't expect you to have a good response to DBS. The good candidates are those who still respond to levodopa but might have impairing dyskinesia or might have what we talk about, these on-off motor fluctuations where the medicine's less reliable or wearing off sooner. Separate from levodopa responsiveness, medication-resistant tremor tends to respond very well to DBS. And as we mentioned before, we want patients who have a reasonable cognitive reserve or cognitive function. There are some candidates who aren't good DBS candidates and will not have as good outcomes if we were to do it in those patients. And those are the ones who do not have a good response to levodopa, those who do have some cognitive dysfunction. The device itself, both obtaining the device and then any programming, is also assisted with the aid of a caregiver. So absence of a caregiver makes someone less than an ideal candidate. There are conditions called atypical Parkinsonisms that by definition do not respond to DBS. So things like MSA, PSP, corticobasal syndrome are not responsive to this technology. And then patients with unmanaged psychiatric disease or severe autonomic symptoms are also not candidates for DBS. So I talked a lot about adverse effects and everything going through it, but the reason we push for DBS in our patients is because there are very good outcomes for those patients who qualify. In most studies, there have been improvements in motor symptoms when they compare it to medication alone, anywhere from an increase of 53% on validated motor scales to 4% compared to medication. So these patients will increase by 53% on these motor scales when it looks at their bradykinesia, tremor, rigidity. Patients also report an improved quality of life, and they have increased time with good mobility and without troublesome dyskinesia. Patients also report anywhere from 30 to 50% of an increase in time when they're on, meaning that their Parkinson's disease symptoms are controlled. This is a complicated process, and for this, it's recommended that a multidisciplinary approach be taken. The typical steps are that a patient is first deemed to be a good candidate based on the criteria discussed by their practitioner. Then all patients should undergo what we call an on-off evaluation, where they come to the office off of their medications. We have them do a rating scale. In our case, it's the Movement Disorder Society Unified Parkinson's Disease Rating Scale. And then after they take a dose of their levodopa, we're looking for a 30% improvement in symptoms. And that's another way to indicate that they're levodopa responsive. After that, patients are typically referred for neuropsychological testing to ensure that there's no cognitive impairment that would preclude them from undergoing surgery. Next, the case is often discussed with a multidisciplinary team, and it's best to involve both the neurologist, the neurosurgeon, and the neuropsychologist to not only discuss candidacy, but after candidacy, what target would be the best choice for the patient. Following this, the patient will undergo 2 surgeries. One is an electrode implantation surgery, and that's just the implanting of the electrode, and the neurosurgeon will use different imaging modalities or other techniques to make sure that they're in the right position. And then the second surgery is the implantation of the pulse generator, which is the battery that's placed oftentimes under the chest. A couple weeks after that, the patient will come into clinic and undergo programming sessions with the movement disorder practitioner. Oftentimes it takes a few settings or sessions to get appropriate settings, but by the end of about 6 months, most patients are on a stable amount of or stable settings that control their symptoms, and they're able to appreciate that benefit that we talked about. So that's all I have for you today. I appreciate your time watching, and I'm excited to continue to offer this exciting technology here at Methodist.